Wonderful. Well, good morning, everyone here in Australia. Good evening to those kind of on the other side of the world in North America, if you are joining in from there. We're really excited today to launch our fourth series highlighting general surgery today in our monthly specialty series. For those of you who don't know, I'm Jacob. I'm one of the co-founders here at CAMSA, and I'm with Angela here, who's our other co-founder. And we'd first just like to thank our two speakers today, Dr. Catherine McDougall and Dr. Rebecca White, for joining us and taking their time really to allow us as medical students to expand our knowledge, our network, and our interest in different medical specializations, into advocacy and into research as well. And really through today's seminar, we will hear from unique perspectives in the field. Particularly, Dr. McDougall will be highlighting the orthopedic surgery side of things, and Dr. Rebecca White from a more surgical oncologist perspective, which is great. Today as well, both speakers are involved in teaching medical students and residents as well, which is amazing. So today's talk will feature three different components. So the first will be Dr. McDougall, the second will be Dr. White, and then the third, we have an opportunity for all of you to ask questions. And we're gonna have an open Q&A period for the matching and intern process and residency process in Australia and in North America as well. And that will take place in the final 20 minutes. So just to briefly introduce everyone, so Dr. Catherine McDougall is an orthopedic surgeon with particular interest in hip and knee surgery, joint replacement of the hips and knees, and orthopedics in the elderly. She completed her medical education here from the University of Queensland. And at the conclusion of her orthopedic surgical training, and after receiving a fellowship with the Royal Australasian College of Surgeons, she completed fellowships in knee surgery at the Gold Coast and in hip and knee arthroplasty and revision arthroplasty in Edinburgh, UK. In 2021, she completed a graduate certificate in safety, quality, informatics, and leadership at Harvard University. And she's currently the clinical director of surgery at the Surgical Treatment and Rehabilitation Service, Metro North Star Hospital and Health Service, and is a staff specialist surgeon at the Prince Charles Hospital. So without further ado, we will get Catherine, you can take it away. And I think you mentioned that you'd like to share screen.
Yeah, I will. Thank you, Jake.
No problem.
Thanks, Jake and Angela, for the opportunity. I'll just share my screen and make sure. Sorry, slideshow. Okay, can you guys see that okay?
Yes.
Okay, so yeah, thanks so much for the opportunity to chat with you today. Jake spoke to me about speaking a little bit about my journey and the processes in orthopedics, and so in the next 10 or 12 minutes, I'll present a little bit about my journey and then allow some time for Q&A around that in orthopedics specifically. So there you go. So we're going to speak a little bit about what orthopedics is about, what my typical week is currently, what my journey was to get there, and highlights and difficulties, as well as some pearls that I think are useful for you at your stage of the journey. So the great thing about orthopedics, it's really the management of injuries and conditions that affect the musculoskeletal system. What can be terrific about it is it affects every single age group. It can affect systemic problems, any limb, really the whole body. So if you have an interest in musculoskeletal type medicine, there is a component of orthopedics that is for you. And I think that is a really great part of our specialty, because we can attract people with lots of different interests, being able to subspecialize in anything from trauma to very much elective sort of arthroplasty, which is what I do, to orthopedic oncology or even pediatrics. So there's a really broad component to orthopedics. As well as that, when we look at the Australian Institute of Health and Welfare data on, the top 20 conditions, there are 5 orthopedic or musculoskeletal conditions that are in the top 10. So almost independent of what you choose in medicine, having some understanding of musculoskeletal medicine is a really important way forward. It's such a huge factor in if you choose emergency medicine or general practice. So make the most of the opportunity as a student to get as much knowledge as you can. I chose arthroplasty surgery, and one of the reasons for that, so arthroplasty is joint replacement. I'm a lower limb joint replacement surgery, so hip and knee replacement. And we think about the quality of life improvements for any type of operation. Total hip replacement is number 2 in the whole whole world after cataract surgery. So I think cataract surgery, the functional improvements you get with cataract surgery are very significant, but so is total hip. Total knee's further down the line, but certainly what I love about it is that it gets people functional and back walking again. What I'm showing you here is the survivorship of joint replacement surgery, because whilst we're doing really well in lots of spaces, there's still work to be done. So if someone has osteoarthritis, which is by far the most common reason to have a joint replacement, the likelihood of revision is 5.6% at 10 years. So, but what's really, really important is that when you look at this age group bracket, and I've managed to format it off a little bit, but the elder age groups are down the bottom in the red, and the younger under 55s are in the green. The revision rate for the under 55s is much higher. So, there's a lot of decisions that we have to make about what operation is right for the total knee replacement person. When we're looking for total hip replacement revision, in fact, a total hip replacement is a great operation for any age when you've got end-stage osteoarthritis. And saying to someone that their revision rate's likely to only be 5% at 10 years, and the functional benefits are significant, is a really big positive for patients who have bad joint arthritis. So this is some of the data that we have to help guide us with our operations, and this sort of joint replacement data is what I use in an everyday sense to make sure I'm making the right decisions for my patients. But moving on to more, I think, what you want to know about, which is really sort of the orthopedic pathway. And this is the pathway in Australia, understanding that it's different if you go on to have your residency in North America. But for us in Australia, we do the general rotating year as an intern, and then an RMO, a junior house officer or a senior house officer, for another 1 or 2 years. Once you've determined what it is that you want to do, orthopedic surgeons generally have to do on average about 3 years of what we call PHO training. So that's you determining that you want to be an orthopedic surgeon, you getting sort of a registrar level but non-training job in orthopedics. Most people do about 3 years of that before being successfully admitted onto the training program. Which again is on average about five years. Some people can get it done in 4, but it's on average about 5 years. Once you finish your training program, and I'm going to speak a little bit more about the journey in a second, you can go on to do a fellowship, which is usually 1 or 2 years, and then become a consultant. So the overall pathway to be an orthopedic surgeon in Australia is that you generally sort of completed your training about 11 years post-medical school. And that's important for you to be aware of. But, it shouldn't limit you. It's just that you have to have that in your head. That's what you're looking at. So once you get out the other side, and I think it's very important that when we talk about what you want to be and what your journey is going to be, is that you look at what life is as a consultant, not what life is as a registrar. Because as you start getting into the hospitals, and I know a lot of you guys might be 1st and 2nd years, but as you start getting to 3rd and 4th years and an intern, you might see what the life of a med reg is and say, I am never going to do that in my life. And I would caution you against making that decision, because it's important to actually get exposed to what life is like as a consultant, because that's where the majority of your work will be done when you're finished. So for me, I have what maybe is not quite a typical working week. And, I'm now about 10 years post fellowship. So I've been a consultant for about 10 years. When I first started, I was very full-time, pretty much all clinical. And now I still do clinical a couple of days a week, and I share that between public and private. So I see patients face-to-face about 2.5 days a week. And that is in an outpatient's room where I see them for their hip or knee pain, advise them about non-operative options, and then maybe book them for an operation. I spend time in theatre, where I do primarily hip and knee replacements, and at my hospital, broken hips. And then the rest of my time is shared between, I have a role as a leadership role at STARS, as Jake alluded to. And so I have some administrative time related to the director of surgery role. And I'm also really excited in the last couple of years to have branched out a little bit into a quality improvement pathway with Queensland Health. So I'm seconded to the health department a day a week, and I do the Get It Right the First Time program, which is a program about making sure what we provide is high value and decreasing unwarranted variation. So, from a professional perspective, I feel like I still have, half my time is still absolutely the face-to-face treating a patient. And then I've got a little bit of time where I'm trying to improve the system, and that really works for me. And as well as that, I have a day off a week because I have a 5-year-old son, and being diversity and having flexibility is not just about being able to be a parent, but moving forward, it absolutely can be. And so in the past, it may have always been difficult to try and see how you can fit all these things in, and it can be challenging, of course. But, at the moment, that's what my week looks like. And I love having a bit of time in my week to be able to be a mum as well. So a couple of other take homes about, how do you get there? Well, I came from a country town. I mean, a lot of you are from North America, so you wouldn't know this. This is the beautiful Northern Rivers of New South Wales, the town of Bellingen, which had 2,000 people in it, I think, when I lived there as a small child. I had teacher parents. I did not come from a medical background. So this concept of only being able to get into medicine or into surgery when you have these connections is absolutely false. I did physiotherapy or physical therapy immediately as my first degree, and worked in it for a few years. And that gave me a good grounding, I think, in musculoskeletal. But I hadn't really had the exposure to medicine until I went to uni. And then I decided that's what I wanted to do. So I then went back and did medicine, and loved orthopedics, and went through that pathway through fellowship. I think when you are a training registrar in any specialty, there are some challenges. You work a lot around, you have sort of 6 and 12 month terms outside of where your home base is. So that can be quite challenging, I guess, socially. That it's something we need to talk about more, because it can make it difficult for people. I had the opportunity as well. I had a 6-month term in Portland, Oregon, which I absolutely loved, at the Shriners Children's Hospital. And without a doubt, the most challenging part of my registrar pathway was the final exam at the end, and having to study for that exam. It's a very difficult exam. You study for it for 12 months. You need to make sure you're well supported, because it's a really tough time in your life, but hugely worth it when you get through it. You have a real great sense of achievement. You move on from your final exam to fellowship, which are sort of almost the best days of the that career. So you go from the worst days to the best days, because in fellowship you're traveling the world. Often you get to meet people from lots of different places. You don't quite have the responsibility of a consultant, and you're really consolidating your knowledge. So what are some of the highlights for me as being an orthopedic surgeon? And I've purposely not gone into too much of the nitty-gritty of, you know, the exact things I do every day. But without a doubt, in orthopedics, it's the patients. And what we are really lucky to do as orthopedic surgeons is we make people better. So if someone comes in after they've injured themselves and they've, you know, broken their ankle or broken their hip, you can fix it and you get them functional again. For me, someone who works mainly in arthritis and arthroplasty, these poor patients have, you know, terrible disease, terrible functional limitation and quality of life, often elderly, often living at home, and the fact that they can't walk means that they can't get out and about, so it affects their socialization, and they have their hip or their knee replacement, and it literally does change their lives. And that's what I love about it. You know, I love the technical component of an operation. There's a lot of maths in orthopedics. There's a lot about angles and doing things consistently, which I enjoy. The feel in orthopedics, the sort of the vibe, so to speak, I find really great. It's a bit casual, it's a bit fun, people are friendly. I've had wonderful mentors, and so that they're some of the things that would be really great. With respect to the difficulties, I think it's important to note that training can be very isolating socially when you get sent around to lots of different places. And, you know, I think you're working really long hours, and so you don't often get the opportunity to sort of get ingrained in that community. And it can become all encompassing. So it's really important that you are able to determine that, you know, it's work. It's not, it doesn't have to be everything about your life. It's just a portion of your life. And as I said before, look at the life of the consultants, not the registrars. So before we get on to some Q&A, my little pearls for any type of, well, really any type of training in medicine, but certainly in orthopedics. And that is, don't forget where you came from. I purposely always put up this country, the picture of my country town, and mention that I didn't have a medical background. And I think that that's important, because you want to make sure that as you go through this situation, a lot of people are going to tell you how great you are, and you want to stay very grounded. You want to always treat people with respect, and it doesn't matter you know, who they are in the hospital and where they sort of sit within that hierarchy. If you treat people well, they will treat you well, and, you know, life's happy. But it's just something we should be doing. I say don't be in a rush, and I know that's different in the US system, but sometimes people are in a rush just to decide on one particular specialty, and they lose the opportunity to get broad medical experience. You know, be a good doctor first, understand medicine first, be sure that it's what you really want to do. Every year we are troubled by many good people miss out on getting onto these training spots, many good people, and they commit years and years of their lives to it. And I'll say to you that none of you are, you all have the ability to do many things and do it well and get happiness in a lot of different areas. So just make sure you keep that broad frame of mind and keep broad interests as you go through training. Keep your life interests as a priority. Doesn't matter what it is. You can exercise or paint or do music or read a book, but make sure medicine doesn't just completely swallow up the whole part of your life. Start your research now. You've mentioned a little bit about research in the introduction to this, and getting involved into some projects and experience is a good idea. I've mentioned keeping people, treating everyone with respect. All of surgery and medicine in general is about decision making. Really work on that. Work on being a logical and safe decision maker, and work on being honest. And most importantly, through your medical school journey and your junior doctor, senior doctor journey, make sure you look after yourself and your family. You have a responsibility to do that. And if for some reason things are getting too much, you need to put your hand up and say that you need a little bit of help. It happens, and there's always going to be people out there to help you out, because it can be quite a stressful journey at times. And that's me, my perspectives on my journey. So I don't know whether anyone has any questions.
Awesome. Yeah, so if anyone has questions for Dr. McDougall, we'll take some of those now, and then we'll transition over to Dr. White. Everyone can use the chat as well for any questions. I had a quick question, actually. So I know, and I know you've done a little bit of work in this specifically, but the use of kind of stem cells in total hip replacements and their kind of use. But more recently, we hear about platelet-rich plasma therapy. I don't know if this is anything that you're know too much about, but I just think it's a pretty fascinating thing to think about, and how that may have practical use in orthopedics down the line, or what your stance is on it.
Thanks, Jake. Good question. So I don't think there's any doubt that biologics or more research or understanding into what causes osteoarthritis is our future. So then we're talking about, if we understand why it occurs, then there's research into both preventative options and treatment options in that non-invasive space. In truth, we aren't there yet. So really, people are trying to study, you know, the platelet-rich plasma, different types of synovial cell and synovial fluid replacements. And there's some early, evidence. I guess it's just on this, it's almost just pre where we need to be able to say we've got strength for it. So I'm sure that's going to be a huge component of the future, but at the moment, we aren't there to be able to say that it's actually effective. What we do know now, in knee arthritis in particular, is that obesity is an independent risk factor for developing knee osteoarthritis. So it's not just people who are overweight don't get knee OA because of the mechanical challenges. People who are obese are more likely to develop osteoarthritis of their knees. And so it's related to the metabolism of fat and probably an inflammatory pathway. So I think that's probably where there's going to be a lot of exciting change moving forward. But you touch on I didn't have time to speak about it today, but non-operative pathway absolutely needs to be the first line of treatment. We need to have ensured patients have optimized the non-operative pathway before we go ahead to an operative pathway. But so watch this space, I think, with your biologics.
Awesome. Thank you for that. Let me just check the chat here. I'm not sure if anyone has any more questions at this time. Okay. Does anyone have any specific questions relating to the Australian pathway through internship and whatnot? If we don't, we can also save those for later after Dr. White. But now's the opportunity for me. We have a question. Is there an integrated pathway in Australia?
Mohammed, I'm not 100% sure what you mean by that. An integrated pathway. Can he unmute? Do you mean a general surgical before you go into orthopedics, or? I don't understand.
Let's see.
See if we can unmute.
Okay, he should be able to now.
Thank you so much for the opportunity. So by integrated, I mean, for instance, in the US, sometimes you can merge the general surgery and your fellowship into one integrated program, save a couple of years in the process? I was wondering if it's the same in Australia as well.
It's not, Mohammed. So orthopedics is slightly separate. We were through exactly the same training program as RACS. The application is still through the College of Surgeons, but in Australia, you apply for a specific surgical pathway, and that is either general surgery or one of the subspecialties or orthopedics, and you go and get a fellowship within that pathway. Whether then, if you completed that fellowship and decided you want an additional one, so I guess the type I'm thinking of, within general surgery, for example, if you want to be a colorectal surgeon, they finish their general surgical training and then do an additional 2 years fellowship to be able to then become a colorectal surgeon, but they're still a general surgeon. But if you were, say, wanting to be an orthopedic surgeon and a general surgeon, we don't have that combined pathway. You might get some credit to lose some years perhaps, but essentially you do one and then do the other.
Okay, great. Thank you so much. I don't think there may be any more questions left. So I wanted to say thank you so much, Dr. McDougall, for sharing your knowledge with us today and providing us with your valuable time.
My pleasure. Thanks for having me.
Thank you so much. So Jake, let's change the slide to Dr. White. Perfect. So our second speaker is Dr. Rebecca White. Dr. Rebecca White is a general surgeon and a surgical oncologist who specializes in treating tumors of the pancreas, liver, bile duct, and upper GI tract. Dr. White is part of the GI cancer unit at the UC San Diego Health's Moores Cancer Center. As a surgical oncologist at an academic medical center, Dr. White instructs medical students, residents, and fellows at the UC San Diego School of Medicine. Her research focuses on novel tests and therapies for early detection and improved treatment of pancreatic cancer. She has published over 50 peer-reviewed articles in many renowned journals. So prior to joining UC San Diego Health, Dr. White was an associate professor in the Department of Surgery at Duke University Medical Center. She completed a fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center and residency in general surgery at Duke University School of Medicine, where she also earned her medical degree. So without further ado, Dr. White, you can take it away.
All right, thank you so much. I'm going to try to share my screen. Let's see, this will continue. All right, can you see my screen?
Yes.
Okay, great. And I want to thank Dr. McDougall as well. I'm going to focus a little more generally on my pathway to becoming an academic surgeon and less on my clinical specialty. And I think you're going to hear some recurring themes with her talk. So again, thank you. You already gave some of my bio, but just to elaborate a little bit. I grew up in North Carolina on the East Coast of the United States. I went as far away as possible for my undergraduate degree. And then I went back to North Carolina for my medical training. And I think up until that point, I feel like those decisions were pretty easy ones. I mean, Stanford was like my dream school. Duke was the best medical school I got into. Those were no-brainers. And so I structured my talk in terms of some of the harder questions, okay? And now these questions are not necessarily in this order. These are questions that you may have to ask yourself over and over again. But, I think the first question that I was faced with, and maybe you are also facing this, is, are you a proceduralist or are you a non-proceduralist? And I think people early on kind of figure this out, like whether you like fixing people, like Dr. McDougall said, or whether you're more of a thinker. And so, I think for me, this was pretty obvious. I was considering OBGYN as well. That's another procedure heavy specialty. But, once I was exposed to general surgery, I saw the light. I mean, I think, I'm half joking when I say this. I mean, I think everyone deep down wants to be a surgeon. That maybe that's not completely true, but I mean, I think everyone, sort of enjoys the excitement of surgery. It just that not everyone chooses that as a career for a variety of reasons. But I mean, I think to me, the appeal of general surgery is just, how broad it is, how it can be a launching pad for so many other specialties. And at least the way it's structured in North America, most other than orthopedics, which is completely separate, many surgical subspecialties start with general surgery as the base, which gives you that extra time to get exposed to many specialties before you commit to one. So for me, I chose general surgery. So, once you decide you want to do general surgery or basically any specialty, the next question is, how do you choose a residency? And there are many factors. I'm going to opine that the clinical training that you're going to get in residency is not going to change. It doesn't differ as much amongst residencies as some of the other things. At least in the United States, I feel like there's a lot of parity in terms of the clinical training you get. I mean, they're going to ensure you get adequate numbers of the basic important cases. And the reality is that most people then go on and do a fellowship. So probably the clinical training you get in residency is not quite as important as the clinical training you're going to get in fellowship. So you need a good training, but that's not the most important factor. I think the most important factor in choosing a residency is, are there success rates? Is it going to get you where you want to be? So if you want to be a pediatric surgeon, for example, does that residency have a good track record of putting people into pediatric surgery fellowships? For me, that was surgical oncology. And so, I chose, Duke because it had an excellent track record of putting people into the best surgical oncology fellowships. Another factor, which wasn't very important to me, is whether that residency offers research opportunities. And there is quite a bit of variability here, ranging from none at all. I mean, some residency programs that literally offer nothing other than maybe the occasional, clinical research project, to others that actually require a couple of years of dedicated research time. And then there are, of course, all the other factors that go into your choice, such as geography and subjective sort of fit things. So like I said, I chose to stay at Duke. I had been there for medical school. I stayed there for residency, and that was, for a lot of reasons. It was a known commodity. I knew they offered good success rates, and they had a very strong commitment to resident research. And in fact, we were required to do at least 2 years of research in the middle of our residency. Now I'm going to take a little tangent here because, it's not just you choosing the residency, they have to choose you as well. So, how do you make sure that the residency you want chooses you? The first step is, of course, having good grades and scores. That's obvious, and that's maybe easier said than done. But in addition to that, everybody has some control over their CV. And, there are a lot of ways you can, make yourself look better on paper. Just making that extra effort to get involved in, whether it's research or, volunteering to write up an interesting case report, offering to help a professor you meet write a review article. It doesn't even really matter what it is, but you want to make yourself an expert in something. It can be something tiny. But when you go to interview for residency, it's way better to be able to show that you have had a deep commitment to something, whether it's a research project or an extracurricular activity, than just being a broad dabbler. So often when we review medical school, when we review applicants to our residency program, people have done, oh yeah, I've done like 50 different things, an hour a week. And that's not as appealing as someone who has just really focused on one thing that is clearly important to them. And then lastly, prepare for your interview. I know it's a lot of work, but get to know the program you're interviewing to, do research, find some names of people that you might want to work with, and then be armed with some questions that are specific to their program. Okay, so the last question, well, this is not the last question, but in terms of preparing yourself for residency, is whether and when to take off time for research. This is a big question that I get a lot. So, it's hard, I know, to take off time in medical school because it's usually not paid for. In the United States, though, for certain very competitive specialties, it is not required, but it is definitely a strong advantage if you've done some time off research, such things like orthopedics or ophthalmology. I'd say more common, though, like I said, is to take time out during residency. This is necessary for certain subspecialty fellowships like pediatric surgery. Our general surgery residencies are usually 5 years unless you're in an integrated program. And the most common time to do this is after your second or third year of residency. This is a time where you've gotten some clinical skills, but not so many that you have a lot to lose. Of course, if you love research, you can take off time at every opportunity you get, but that's hard. Eventually you do need to finish your clinical training. But I would say this, though, it gets harder and harder to take off dedicated time for research as you progress through your career. Once you've finished your clinical training, the allure of doing cases and making money is going to make it a lot harder to just take off a year or two to do research. So I think the time to do it is either med school or residency. And so that is what I did. I did not just 2, but 3 years during residency, which made my residency 8 years. I then matched into a very competitive surgical oncology fellowship at Memorial Sloan Kettering. I was very much interested in research. So then I came back to Duke. I started a lab focused on pancreas cancer. I was there for 9 years, and then I moved to UC San Diego, and I just got promoted to full professor, and I have an NIH funded lab. And so along the way, you're going to ask, and when does family fit into all this? So, there is no easy time to do it. So the answer is, whenever it works for you. Again, in the United States, a popular time for women, especially to have children, is during those research years in residency. Now, that works well if you have a spouse who is not in medicine and who is making some real money. The advantage of waiting until you finished your training and started a real job is that you actually have money to hire good help. But there's some risk because everybody knows that the risk of infertility goes up with age. So for me, I met my husband, who was also a surgeon. He's now a thoracic surgeon. We met in residency. And therefore, since we were 2 residents working a lot and we were apart for 2 years, we waited until we were done with our training. And we had our 2 children basically immediately after starting my faculty job, and then another one 2 years later. And now they're teenagers. But it worked out for us, luckily. So the last question that I have, and this is the one that you will keep asking yourself over and over again throughout your career, is, to stay in academic surgery or not. I think the appeal of academic surgery is that it combines, the short-term fulfillment of patient care, fixing people, with the long-term gratification of teaching residents and doing research and contributing to generalizable knowledge. Those are the reasons to do it. It is not for the money, because you do not make as much in academic surgery as you do in private practice, at least in the United States. So it's not for the money, although there are definitely some other benefits to being an academic surgeon, including getting to give international talks, sometimes actually getting to travel to give those talks, the prestige of being an expert in something, and occasionally getting awards. Neither of those pictures is me, by the way. And just again, a shout out to women. We are now very well established certainly in medicine, where we're now 50% in the United States. We're not quite 50% in surgical residencies. But it does continue to increase. And at least at our program, we've had several years where it's been 50-50 or more women. And then as you go up the ladder of academics, the numbers, drop off, but still, women can do it. Women can be academic surgeons. Now it's hard. And, trying to balance, patient care, research, teaching, it's crazy. And I like this Betty Friedan quote. Who wrote The Feminine Mystique. You can have it all, just not all at the same time. So you just have to accept that you cannot be the best at everything all the time. So my advice for everyone, not just women, is, I think the key to making it work is trying to align your clinical and research interests as much as possible. There's a lot of efficiency to be gained if your research is something related to your clinical specialty. It also makes your grant applications more competitive if you're a clinical expert in that field. I think Dr. McDougall said something similar, but I mean, be nice to each other. We shouldn't be competing. There are enough people that we're as clinicians, we're competing with basic scientists for grant funding. So academic surgeons need to be nice to each other and help each other. Be mindful of work-life balance. Even if you personally don't need a work-life balance, respect others who do, and be persistent, because definitely you're going to meet with failures, and so you just have to keep trying. So I am happy to answer questions as well, and that's my email.
Okay, awesome. Thank you so much for your talk, Dr. White. Let's see if anyone has any questions in the chat. Well, to kick it off, I have a question for you. Oh, the question just came up, but I can ask mine. So I'm really interested in your research, and I've looked into the types of research that you do. And one of them that really stood up to me was your current research on combining irreversible electroporation with immunotherapy for systemic treatment of pancreatic cancer. So I was wondering what your opinion of this novel technique and how it compares to, for example, small drug discovery and using orally bioavailable drugs to treat pancreatic cancer.
Well, I'm going to give this as an example of why it's good to combine your clinical and your research interests. Mm-hmm. This is a research topic that a non-surgeon would have a lot of difficulty doing, because, basic scientists, they can study small molecule inhibitors in cell lines as well as or better than I can, but they don't understand what it's like to touch a human tumor and treat it with electrical probes. That is something that requires firsthand sort of knowledge of anatomy, and so that gives me an edge. So that's just more of a strategy, but I think in terms of how it compares to small molecules, I mean, let's face it, drugs alone aren't working very well for pancreatic cancer. So, I think we need to try something different. And, this is a very novel approach that, has it doesn't replace drugs, but may have potential to work synergistically with drugs.
Mm-hmm. Okay, thank you. And another question from Kane is, you said that one of the first questions to ask when considering being a surgeon is whether or not you are a proceduralist. How do you determine whether or not you are a proceduralist as a person?
That's a good question, but it reminds me of a story that a friend of mine told me of when she was on her internal medicine rotation, and one of the other students on the rotation, they'd been sitting in a workroom, working on a computer and reading about patients for hours. And her friend said, I just love sitting here and thinking about my patients. And I think we all as surgeons, completely understood what she meant when, none of us felt the same way. I don't like just sitting and thinking about things. I like doing things. That's a gross oversimplification. And there are, just to make the point, I mean, there are medical specialties that incorporate procedures. So, if you're really not sure if you're a proceduralist or not, you'll have other chances. So for example, gastroenterology, that's a medical specialty, but it does, you can go down a procedural heavy route where you become more of an interventional gastroenterologist and do things like endoscopies and ERCPs. And so, if you're on the fence, you may have chances to circle back.
Okay, and while we wait for more questions, another question that I have is, what would you recommend students who are in their first and second year of medical school and they haven't yet found their specialty of interest, but are involved with a lot of research that's very broad? I know you touched upon the aspect of being really, really good at one specific thing so that it makes you stand out as an applicant, but how would you recommend students who are very broad with their research so far?
Yeah, it's hard because I know when you're first starting off, you have to start off a little bit broad because you may not know, what it is that you're passionate about yet. So I'm not saying, I think that's great. You should try to expose yourself to several different specialties and, as much as possible, if you have opportunities to shadow different specialties and just see what they're about. I just think at some point you do have to kind of narrow it down. And I think, and there's time for that, maybe in your, third year, try to focus on something. And again, it's about the salesmanship. Even if in reality you did 100 different things, when it comes time on your application, try to pick something that you feel like you can focus on as the thing that you're most passionate about and sell it.
Okay, awesome.
Oh, I saw this next question. I saw one of the next questions here,
Okay.
but here, do you want me to read it out loud?
Yeah, sure.
Okay,
Awesome.
All right. So how could students with surgical interests also integrate other research interests like public health or policy? That's a really good question that I didn't touch on because it's a little, just because I'm not in that field, but I'm just because I'm focused on basic science research, you can be similarly academic with health services research. It's just a slightly different, it's just a different pathway. A very popular thing to do in our country is to get a master's of public health. And so a question people ask is, okay, do you need to get one of these additional degrees? And, again, no, you don't have, the answer is no, you don't have to get an additional degree to become a health services researcher. But it is something that some people do as just, as something that can differentiate themselves. And so if you have that opportunity, you could either pursue that as a medical student or potentially some residency programs will allow you to pursue one of those types of degrees instead of lab research during the research years. There was a question about, so pancreatic cancer isn't known for positive outcomes. So how do you respond to the emotional toll of your work? So this is not unique to pancreas cancer. This is an issue with, any specialty where people die, whether it's ICUs or, cardiac surgery, but yeah, it's hard. And I'm not saying you have to become like a robot, but you do have to some extent, compartmentalize. And, you should, I hope that I never get used to patients dying, but, I think I do have the ability to try to separate that. And, when I go home, try not to dwell on it too much. It's our job to do the best we can. It's a bad disease. Sometimes people die. You can't let it take over your life. Anyway, those are all good questions.
Yeah, I think that almost ties into I think one of the last questions we have here for you, which was how to respond to the emotional toll. But I think you've touched upon that.
Yeah, that's what I was trying to
Yeah,
respond to
which
that.
yeah, wonderful. Okay, and then Catherine, I loved your talk, Dr. White. The systems are very different, but we're working towards the same thing. That's yep, amazing. Okay.
And I just want to maybe, I don't know if we're over time or not, but I just wanted to highlight that there are different ways to structure your life in terms of helping work-life balance. I mean, I don't have the flexibility to take a day off a week, but you know, like I think like Dr. McDougall said, she is able to take a day off a week, but I do feel like by having a career I'm basically 50-50 research clinical, which means that I'm in the OR less and my research time is therefore more flexible. So it means that, I mean, I still work a lot, but if I need to leave early, you know, to go to my son's baseball game, you know, I often can, with advanced planning, arrange it so that I can go to my son's baseball game. You know, it just means that sometimes I'm catching up on work at night, but the research time is a little more flexible than the clinical time.
Great. Mohammed.
Oh yes. Does being an academic surgeon give you more freedom to try new techniques and therapies in your practice? Absolutely. You know, I think it's one of the benefits of being in an academic center, and you know, and yeah, you wouldn't be able to do some of the thing like the irreversible electroporation that I do for pancreas cancer. Like I wouldn't be able to do that if I was just in a community hospital. And so I think in general, being part of a large and academics practice, you know, you just get to you get more interesting cases, and do more interesting types of surgery. So it's exciting.
Great. Okay. If anyone has any last questions, feel free to put them in the chat for both Dr. McDougall and Dr. White. If not, though, I'd like to reiterate what Angela said and just thank you both for your generous time. I know, of course, you do have busy schedules, and for us medical students, we definitely appreciate, you know, hearing and learning and getting a little bit of insight into kind of the life and the life balance and the pathway and whatnot. So thank you so much. And we will keep in touch with the both of you. Angela and I will stick on here for a little bit. If anyone has any more general questions about logistically more logistics concerning residency and internship applications in North America and Australia. So if anyone has any questions about eligibility, requirements, timelines, exams, application standouts, tips, Angela and I can stay on here. But Dr. White and Dr. McDougall, thank you so much again. And for everyone else, thank you for attending. And we look forward to hosting our next specialty series in August. So thank you, everyone.
Thank you.
And have a great rest of your day or your evening.